Good morning, everyone. Thank you for joining us. What time are we at here? We're at 8:02, so we'll get started on this very, very cold Friday morning. I'm up in Uxbridge, and I think it was -24 this morning when I woke up. My dog was not thrilled about going outside. I'm Dr. Becky Ray. I'm the Regional Primary Care Lead for the Central East Regional Cancer Program. Happy to have you here today. Just a couple of housekeeping items before we get started. Because everyone signed up today, you'll receive emails for future webinars and future events that we do. If you prefer not to be on that list, you can send a message to Caitlin Loudon, and she will put her information in the chat. But we would like to continue to use this list to invite you to future webinar series and events that we're hosting for the Central East Regional Cancer Program. Today, we are doing our second in our series of HPV-related cancers, and we are lucky enough to have Dr. Christina Ioannidis with us today. So, Christina, if you have not had the opportunity to meet Dr. Ioannidis, she is a community otolaryngologist based in Durham Region. She did her undergraduate degree as well as her master's in public administration at Queen's University, followed by a medical school at the University of Western Ontario. She then did her residency in otolaryngology at Western before starting practice here in the Durham region in 2022. Her practice has a focus in laryngology and skin cancer of the head and neck. And I was just chatting with her before we started. She recently helped me with a case of squamous cell carcinoma of the vocal cords. So this is a very timely session, actually. Outside of medicine, she loves to travel with her husband, Jamie, and learn to cook her family's Greek recipes. She's also learning to curl, the sport, since moving to Whitby a few years ago. So welcome, Christina. Thank you for being here.
Thank you so much, Dr. Ray. I am so happy to be able to be here with everyone. I'm overwhelmed by the number of people who are interested to hear a little bit about HPV-related cancers of the head and neck. I think it is a very interesting topic, and it's something that has grown really significantly over the last, 2 decades or so. And so it is something that's important to our patients. It's something that is happening all the time, and maybe we don't have a lot of insight into the diagnosis and treatment. So I'm so happy to be able to share that so that all of our patients have a little bit more information. So I just wanted to talk a little bit about disclosure. I mean, it's part of our kind of general presentation. I don't have any financial disclosures or sponsors. To my knowledge, there's no sponsors of this program. If you have any, let me know, but none here today. Just a little bit about where we're going to go. I did want to start by talking a little bit about head and neck anatomy as well as other sites of head and neck cancer. HPV really is limited to oropharyngeal cancer, and so that's what we're going to be focusing on today, but did want to give a little bit of a brief overview about head and neck cancer as a whole. And then I figured I would go into symptoms and screening to talk a little bit about what you might be seeing in your clinics and how to differentiate, the red flags from the not. I did want to talk obviously about diagnosis and treatment and what I see in my office and kind of once patients come to me, where they go on to. I will talk a little bit about non-malignant related HPV lesions, which are maybe a little bit less known. And then obviously talking a little bit about HPV and vaccination, because although we originally talked about HPV vaccination in terms of cervical cancer, we now know that there's a whole wide range of HPV-related cancers that can be mitigated using HPV vaccination. So just wanted to briefly touch on head and neck anatomy. I have just a very kind of brief overview here, obviously. basically want to talk about cancer that can be in any of these different sites. So you can get sinonasal cancer, believe it or not, nasal cavity cancer, oral cavity cancer versus oropharyngeal cancer. So there's a huge difference between the two, actually. The oral cavity actually ends at the junction between the hard and soft palate, as well as the circumvallate papillae, which are if you open your mouth, you might see little tiny bumps on the very back of your tongue. Those are the circumvallate papillae. Oral cavity cancer is very different than oropharyngeal cancer, mostly related to the HPV association. Um, though people with oral cavity cancer, often they are patients who have had a lot of history of smoking or alcohol use, especially when you notice dependent areas of cancer, meaning cancers underneath the tongue. Um, and those definitely have different treatment and prognosis. In fact, we'll talk about this a bit more. Oral cavity cancer is mostly a surgical disease, whereas oral cavity cancer is mostly a surgical disease. Oropharyngeal cancer is actually mostly treated with chemotherapy and radiation. Then kind of when you pass that junction between the hard palate and the soft palate, go past the circumvallate papillae, that's the oropharynx, and that's what we'll be kind of talking about today. Above that, you have the nasopharynx, so the portion behind the nasal cavity, and below that, you have the hypopharynx and the larynx. Hypopharynx meaning kind of the entryway into the esophagus, larynx meaning the voice box and related structures. One thing I kind of want to point out here is you might be able to see, I'm not sure if you can see my mouse there, but you can see that the oral tongue actually goes or the tongue, I should say, goes quite far into the back of the throat. And so when people talk about base of the tongue, they sometimes mean the floor of the mouth here in the front of your mouth. But the actual anatomic definition of the base of the tongue is actually the part that is in the oropharynx. Imagine, and I'm not going to do this obviously on camera, but if you were to try to gag yourself, that is the base of the tongue. And so when we're talking about base of tongue cancer or we're talking about oropharyngeal cancer, that's kind of all back in an area that on regular normal physical examination, you really won't be able to see. Some patients, you can get a glimpse, you can get a reasonable view of the tonsils, glimpse of the posterior pharyngeal wall. I have, some very select patients I can see all the way down into their epiglottis just because they can open their mouth so wide. But some patients and a large majority of patients, they have like a higher riding tongue. You really don't get a great view unless you're A, really looking for it, or B, are working with some specialized instruments. So just wanted to kind of talk a little bit more about the oropharynx. So I kind of have this nice little view of the oropharynx here. Um, Oropharynx has actually 4 subsites when we talk about head and neck cancer. The soft palate being one, the base of tongue, so meaning the back of the tongue that goes down your throat being another. The palatine tonsils, and the palatine tonsils are those are the ones we talk about as tonsils. Just briefly, we have multiple different tonsils. You have the lingual tonsils, the palatine tonsils, and you actually have the adenoid pad, which is a type of tonsil as well. But the palatine tonsils, meaning the 2 little golf balls at the side of the throat there, those are considered part of the oropharynx and a subsite for cancer. And then again, the posterior pharyngeal wall. Talking about boundaries, the junction between the hard and soft palate, all the way down to what's called the vallecula, which is where the base of the tongue inserts onto the larynx. And we include the lingual surface of the epiglottis as part of the oropharynx. So the epiglottis, there's a lingual surface and a laryngeal surface. The lingual surface is part of the oropharynx as well. So just kind of trying to give you a little bit of a anatomic perspective. So when we talk about oral cavity versus oropharyngeal cancer, and when we're talking about HPV cancer, we're talking about oropharyngeal cancer specifically. So I mentioned a little bit about how it can be really hard to take a look at the oropharynx. You might think, well, how am I going to get a good look? I will talk a little bit about my approach to an oral cavity oropharyngeal exam a little bit later, but I will talk also a little bit about how I view the oropharynx in my office, which is with nasopharyngoscopy. So this is a nasopharyngoscope or a nasopharyngeal laryngoscope, if you want to be specific. if you refer someone to my office, they are almost certainly going to get a scope. Probably not children, but in the vast majority of people who are having, any sort of complaints about the throat, if they're having any nasal complaints, really, this is the way that I get a really good view of where we're going. It usually takes me about 1 minute, and I will say there's not a lot of good things about COVID, but the only good thing about COVID is that I now have a frame of reference for people to talk about nasopharyngoscopy. I tell them, this will take you about a minute. It will feel a little bit like a COVID swab, a COVID swab in case they've had one before. If they haven't, I tell them it kind of feels like when you jump into the water and you get water up your nose. I do have some freezing in my office. I would say about 90% of people prefer not to go with freezing because it's a short procedure. And the freezing lasts for about an hour. Sometimes they feel like they can't swallow. Even though they can, it just feels a little bit unusual. So that is how I get a really good view. And it's a kind of a mainstay of our treatment and I guess diagnosis. So I had some really wonderful patients agree to share their scopes. I have a device in my office where I can actually record scopes and I can share them with patients, which is really great. So I thought it might be helpful for us. The two patients, this one and the next, I both specifically asked if they would be okay with me sharing their view of their scopes, and they said absolutely. They're very happy to share for education. So first, we're going to talk about a normal scope. So
Kind of. Let's take a look.
as you can see, we're going through her nose there.
So that might be a little bit more.
I choose the other side because she has a slight septal spur. On the right, you'll see her inferior turbinate, on the left, her septum, and there's her nasopharynx. Then now we get to the vallecula, the epiglottis kind of at the bottom there. The V, the white V, those are her vocal cords. And then I kind of get a view of her base of tongue there when she's sticking out. So I'll just go maybe back a little hair just so I can kind of give you a really good view of all that anatomy. So again, the vallecula, base of tongue, that little cartilage piece there is the epiglottis. You get a good view there of her vocal cords. The two little bumps at the back, those are her arytenoid cartilages. They are the cartilages that help to move the vocal cords back and forth. Attachment points for a lot of the muscles. When we breathe in, we open the cords like that. And when we speak or say E, we close the cords like that. So realistically, that was 30 seconds, believe it or not, including a little kind of check at the front to see, which side would be better. And that's a completely normal scope. So if people are worried about what a scope will feel like or look like, that is what a normal scope looks like. And that's about how much, that was probably a really quick one, but between 30 seconds to a minute is very reasonable and normal for a scope.
I do, kind of.
So this is an abnormal scope. So this is a patient who actually came to me through the Emerge because she'd been having this globus sensation for a few months, and she got a CT scan in Emerge, and well, it was pretty obvious what it showed on the CT. So I will just show you the scope.
So take a peek here.
So again, a little tight on this side.
No, the other side. Was the other side? Okay. Yes. I think that's a little bit easier. Great, you're doing fantastic. Worst part is over. Just breathe in through your nose for me. Perfect.
So you can see that's not normal. So we just passed the nasopharynx. We're into the oropharynx. That lump there shouldn't be there, as you saw in the last one. I'm going to spend a little minute trying to get around it because part of what's really important here is me identifying if I can scope around this tumor, if I can see where the tumor ends. Does it include the epiglottis? Does it, touch or erode through the epiglottis? And is there involvement of the larynx? That helps with staging. It also helps me to think about, hey, how am I going to biopsy this? And so, as you can see, she's gagging a little bit. It is a little bit hard to get around. I will get there in a moment. I'm kind of giving her a break here. Back in the nasopharynx, so you can kind of see her eustachian tube orifices on the side there.
Swallow for just a moment, just breathing in and out through your nose.
This is me trying to get her to be a little bit more relaxed as I get a view. And here I'm going to see there's her larynx right there. So I can see that her larynx is not involved with the cancer. the cancer is kind of touching the epiglottis there, but I don't think it's actually involving the epiglottis, but it's actually touching the epiglottis. And anyway, so that's an abnormal scope. This lady actually does have an HPV positive squamous cell carcinoma. And this is actually can be very typical as to how people present it. Can often be very asymptomatic, and all of a sudden, things change just a little bit, and then the symptoms kind of come. So I'll talk about that in a little bit.
Oh,
There we go. So kind of switching gears a little bit because we just kind of talked a little bit about what an examination looks like. Our goal today is to talk about HPV and head and neck cancer. So I figured I'd start by talking about what the subtypes of HPV are in the head and neck. There are benign, malignant, and then less common subtypes. So benign being HPV 6 and 11, malignant being HPV 16, and then to a lesser extent 18. So HPV 16 is our most common strain that's causing head and neck cancer. And then the other that are less common but also high risk for malignant transformation are 31, 33, 45, 52, and 58. For those who are familiar with the Gardasil vaccine, shocking, these are all the ones that the Gardasil vaccine covers, which is great. That is the whole point, right? So these are the ones that we kind of take a focus on. When we talk about HPV-related head and neck cancer, really oropharyngeal cancer is the one that we're talking about. And 90% are squamous cell carcinoma. Of course, like there are weird and wonderful things. You can have lymphoma in that area as well. Minor salivary tumor, sarcoma, the list can go on and on of like weird and wonderful. But when I see a lump in the head and neck that looks like a cancer, 90% of the time, this is an squamous cell carcinoma, either HPV positive or negative. And so for any oropharyngeal mass, we always check P16 status. Technically, HPV testing gold standard would be E6 or E7 mRNA expression, but in the province of Ontario and most places, we use P16 testing as a surrogate for HPV status. So we assume if if P16 is positive, the tumor is HPV positive. And the important thing to know here is that P16 positive and P16 negative disease are very different. P16 negative disease is much more like oral cavity cancer in terms of population and presentation, whereas P16 negative is very different. And so let's talk a little bit about the different populations you'll see. So P16 positive cancer or HPV positive cancer is generally younger, usually healthy, usually non-smokers. P16 negative, usually diagnosed older. Those are people that I see in like their 70s, 80s. Usually we'll have some sort of association with tobacco or alcohol use, and often are less healthy when they do make it to diagnosis. The average age of diagnosis in oropharyngeal squamous cell carcinoma is around 55. And that number is actually brought down by the HPV positive group. We see kind of a bit of a bimodal distribution. So, when I see somebody who is like 45 to 55 presenting with these symptoms, it's much more likely that it's an HPV positive type cancer. Presentation is also different. So P16 positive patients tend to present with less symptoms and often will just present with big cystic nodes. Either on CT or on physical exam. So they might not present with a standard oral cavity oropharyngeal symptoms. They might actually just present with a neck node. And truly, if I see a patient who's like 50, 60 or more who has just a neck node with no other symptoms, I'm taking a really close look inside their oropharynx because that's like a very, very, very common presentation. The prognosis is also a little bit different, so we'll talk about that in just a sec. I want to talk a little bit about incidence and prevalence of HPV-related oropharyngeal squamous cell carcinoma. Oropharyngeal squamous cell carcinoma accounts for about 11% of head and neck cancer. And the incidence of HPV-related oropharyngeal cancer is on the rise. If you asked me this question 5 to 10 years ago, I probably would have told you it was between 50 and 70%. But there's a newer study in the last 2 years that actually looked at rates of HPV-related oropharyngeal cancer in Canada. One of my mentors at Western was part of that study, and it's actually showing now closer to 80% of oropharyngeal cancer is related to HPV. the average rise is somewhere between 1% and 2% a year, and projected. So this kind of the second graph at the bottom shows projected cases over the next, I believe it's 20 to 20 years. And like the I guess number or percentage of HPV positive oropharyngeal cancer rates are projected to rise. Is like the number is like 45, 47%, and then mortality, like deaths, are projected to rise by about 50%. So that's a lot, right? We're talking about a disease that is not only a, reasonable proportion of cases that are out there, but is projected to rise by a significant number going forward. That's something that is going to impact your patients. Like the chances that somebody in this room at some point is going to notice or identify an oropharyngeal cancer that's potentially HPV positive is high. The Interestingly, the incidence of oropharyngeal squamous cell carcinoma is different in different parts of the world. And we think that it has to do with differing attitudes regarding sex, because a big risk factor for HPV related oropharyngeal cancer is, and we'll talk about it, is like sexual habits. And so in places like, for example, Canada and the US, Australia, those rates are much higher, whereas countries where people have less sexual partners over their lifetime, the rates are generally lower. So I mentioned risk factors. What are some risk factors for HPV positive oropharyngeal squamous cell carcinoma? Male gender, it's like I think 9-to-1 male to female. Younger age at first sexual contact, less than 17 years old, has been proven to be a risk factor. High number of lifetime sexual partners. I don't know where 26 came from, but it was in this, there was a kind of landmark study that did look at these risk factors, and the number they came up with was more than 26, increases statistically your risk of having an oropharyngeal cancer. But more importantly, lifetime number of oral sex partners greater than 6. Is also a risk factor. So that's kind of like, I think, just an interesting thing. I think it contributes a little bit to a bit of a stigma around oropharyngeal squamous cell carcinoma, as it shouldn't. But I think when you talk to patients about this, they'll kind of ask questions about this. And yeah, it is a risk factor that we have to take into account. So I did say I would talk a little bit about staging. Staging for HPV positive versus negative oropharyngeal cancer is different. Currently we're on AJCC 8, and that's what you use for staging. The size of the tumor, I know there's a lot of information on this slide. The size of the tumor is the same for stage on both. Nodal deposits are different. So believe it or not, nodes ipsilateral to the tumor and up to 6 centimeters are still T1 in oropharyngeal HPV positive oropharyngeal cancer. Whereas when you look at, I'm going to kind of shift back and forth between the next couple of slides. When you look at HPV negative or P16 negative oropharyngeal cancer, the T1 is only one singular unilateral node between less than 3 centimeters. So bigger nodes are allowed to count as a lower stage in HPV positive cancer, essentially. And then I looked at, so on the right side of your screen, that's all information direct from the AJCC. I kind of just picked in little bits and kind of put it up there in terms of staging. The left side of the screen is all the notes that I made myself when I was studying for my Royal College. And I thought that it kind of gave a better visual representation of what the staging looks like. So just if you follow me for a second, I kind of have this graph where you have all the T stages on one side and the N stages on the other. And the way that we kind of get an overall stage as you kind of add the T stage and the N stage, and with or without METs, and you get a stage 1, 2, 3, and 4. And oropharyngeal HPV positive cancer, as you can see, stage 1 is pretty wide, right? Like up to T2, which is up to 4 centimeters, up to N2, which is, like some pretty big nodes there, right? Like you can go up to 6 centimeters with even contralateral or bilateral nodes, and you're still stage 1. Whereas when you look at HPV negative, stage 1 is really just T1N0. So that's less than 2 centimeters primary tumor with no nodal involvement whatsoever. So essentially, oropharyngeal cancer gets worse faster if it's HPV negative. I am going to kind of move along because I've been rambling for quite a bit, but let's talk a little bit about prognosis. So this kind of is probably the seminal paper on prognosis for patients with HPV positive oropharyngeal cancer. It's been cited over 7,000 times. Generally shows that HPV positive patients do better. So when I talk to somebody with an early diagnosis of HPV positive oropharyngeal squamous cell carcinoma, I quote like about a 90% chance of a 5-year survival. And when I talk 5-year survival, that's like the end point that we really look at in terms of um, any sort of cancer research. So I mean, you can see here with the graphs in terms of basically overall survival, progression-free survival, it doesn't matter which one it is, HPV positive patients have a significantly different picture than HPV negative patients. And when you talk kind of by stage, those HPV positive patients, they have pretty good survival no matter what. I'm not saying it's amazing. Like obviously we're talking about, 90% at stage 1. But even stage 4 patients, and those are patients with like distant metastases, like they're looking at a 70% 5-year survival. Like that's not insignificant. Whereas you can see the HPV negative group, their survival rates are they decrease very sharply once you get to stage 3 and stage 4. So let's talk a little bit about symptoms that you might see as somebody come in with your clinic. Pain is a big one. Earlier stage tumors don't present with pain. I've had people I've had people present with a neck mass. So the CT that you have here, that's a cystic neck node. And so that's likely what the patient first noticed was a big lump in their neck. And then once you do the CT or you do the scope or whatever, then that's when you see the ipsilateral base of tongue lesion. I have had many, many patients come in with no pain at all. They don't even notice what's going on. Really, it's the neck mass that comes up first. You may have somebody with a hot potato voice. So if you remember the scope that I showed you, I'm not sure if you got a good view of that lady's voice, but she kind of talks like Kermit the Frog, just a little bit. I do show voices with my patients to show them what I'm looking for. So that Kermit the Frog voice, that's a hot potato voice. And that basically is telling me there's something blocking like above the level of the larynx. Dysphagia. So I wanted to just kind of touch a little bit on dysphagia versus globus. So dysphagia means like you're having difficulty swallowing, meaning you cannot swallow, basically. So people who are, going down on textures, like, hey, I can't eat a sandwich anymore. I'm really sticking to soft foods, or I'm limited to, like fluids only. And we do see like one of the big symptoms for oropharyngeal cancer is weight loss, right? And so not because people want to lose weight, it's because they like literally can't eat food because it just won't go down. Otalgia, interestingly, with the kind of shared innervation between the throat and the ear, sometimes people will have ipsilateral otalgia, and may even be like a first presentation, or maybe the first thing they notice. And then when you ask them, hey, have you had any changes to your swallowing or changes to your voice, any sore throat that won't go away? They're like, oh yeah, you know what? Like 4 weeks ago, I started having a sore throat, and it just hasn't gone away, right? So we kind of have that. And then I mentioned in terms of the neck mass, when you are palpating somebody's neck, you are looking for a firm, fixed node. That anything that you put your hands on, it's firm and usually not painful. That is a really concerning sign. And then when you get the CT, often with HPV positive squamous cell carcinoma, you will see cystic nodes like these. So I did want to touch a little bit about the concept of this primary unknown, and I'll just kind of gloss over it. These are people who present with neck mass only. They need a full head and neck exam. They often end up going to the operating room for like biopsies of all the oropharyngeal sites. We usually biopsy both bilateral base of tongue, bilateral tonsil for these patients if we can't find a primary. 40% of primary unknown will have a base of tongue cancer, and 20% will have a tonsil. Usually ipsilateral, and there's a lot of discussion in the scientific community about like, oh, what should we biopsy, whatever. But 40% of these people will not ever have an identified primary, and they end up just getting kind of radiation all the way through. But 60% we find like an oropharyngeal primary somewhere. So it's interesting when you find a firm, painless, fixed lymph node. A lot of these patients will be this type of picture. So, I mean, we talk a lot about cervical screening, right? And I know that the last talk in this series was about vulvar cancer and anal cancer. so we'll talk a little bit about screening. And unfortunately, I don't have a screening test for head and neck cancer. I wish I did. That would be fantastic. We talk all the time about if we could just do a little swab, and send that off to the lab and be like, oh gosh, yeah, you have oropharyngeal cancer. It would free up a lot of time, that for sure. There is some research into like things like biomarkers, epigenetics, microbiome, but we don't have a screening test right now. So we can't do like a, routine pap. We can't do blood work. Like this is physical exam and history is your screening test. And so when you have patients coming in with these symptoms, like they need a head and neck physical examination. They really do. Yeah, this was just about kind of upcoming biomarkers. This is stuff that's happening in the last like within the last 5 years and really is not in the current practice at this point. So if you do have a patient that ends up with an HPV, well, any oral cancer or oropharyngeal cancer, this is kind of the pathway that they're going to go through. So if you are worried about a head and neck cancer, you're going to send them to someone like me in your community. A general otolaryngologist or community otolaryngologist can help you both confirm, deny, and work up. So the first thing we do when I see something like that scope we saw earlier is I look at getting a biopsy. Can be awake or asleep. Most people, just based on like resources, do them in the operating room. But that lady that you saw, like when I'm seeing that lady, I'm thinking to myself, how am I going to intubate her for a general anesthetic, right? Like she's probably not super intubatable right now. And there's a risk that she might wake up with a trach. And ideally, she probably doesn't want a trach if she's managing pretty well right now. So, that is kind of a consideration. Under general anesthetic, that gives us the opportunity to get a better view, identify, where all these structures are, what's involved, what's not. I always get a CT head, neck, and chest. That is part of the staging for all sorts of head and neck cancer, but also specifically oropharyngeal, HPV positive as well. And then these patients actually will get referred onto a head and neck cancer center. So something that is unique about head and neck cancer is it is not treated at every cancer center. There are, I believe, 5 in the province of Ontario right now. So London, Toronto, Sunnybrook, Toronto UHN, Ottawa, and Sudbury. And so those are those are where every patient with oropharyngeal cancer is going to go, right? So it is sometimes a shock for people. Sometimes if they're coming from, like Campbellford to see me, they're like, wait, I have to go somewhere else to go, I have to go further for this treatment. And the answer is like, yeah, unfortunately, I'm really sorry. But that's kind of what it is. The other thing I kind of want to touch about here, and I mentioned it earlier, is that a lot of people, when they have this initial biopsy, especially for oropharyngeal HPV positive cancer, ask like, how did this happen? They're often like younger, healthy people. They haven't smoked, they haven't drank. They're really shocked and they're really hurting. A lot of time I spend with people is talking about how this is like not their fault. This isn't something that they intentionally did. I always tell people 90% of human beings will encounter some strain of HPV in their lifetime. It's like honestly just bad luck if someone develops a head and neck cancer as opposed to just clearing the infection. I do get a lot of questions at this stage about like, did my partner cheat on me? The answer is probably not. This is something that people probably contracted years to decades ago. Um, and the kind of residual cell changes have just been waiting for years to decades before they kind of come out. I have people ask me if they're contagious, if they need to kind of stay away from people, and the answer is likely not. Like your body has likely cleared this infection years or even decades ago. But I'm just kind of mentioning this piece because as we do our diagnosis and our workup, these are the questions that our patients have, and these are, their real fears and worries about HPV positive cancer. And so I try my best to kind of dispel some of those feelings, but certainly, always happy for others to include themselves in that too. Just wanted to touch a little bit about what treatment looks like for patients with oropharyngeal squamous cell carcinoma. It is pretty much the same for HPV positive and HPV negative. The standard of care at most centers is radiation plus or minus chemotherapy. So it was previously, 6 to 7 weeks of high dose radiation, 70 gray, concurrent chemotherapy, usually like, cisplatin, sometimes carboplatin, for patients under 70. So it is a pretty young cutoff for chemotherapy, but I would say over the last 5 to 10 years, there's been a push for de-escalation of therapy, either decrease in total dose, like from 70 to 60 gray, or sometimes decrease in time from 7 to 6 weeks. There's some preliminary data that shows some good progression-free survival for patients while still improving their swallowing outcomes. I'm going to touch briefly on Orator. It was a trial actually done mostly through Western, so this is why I'm very familiar with it. Multi-year trial to compare outcomes of transoral robotic surgery versus standard treatment, radiation plus or minus chemo. So transoral robotic surgery, I don't know if you've ever seen a surgery robot, the ones they use for like prostate and kind of like minimally invasive like gynae and stuff. It's the same robot, but we were basically using it in people's mouths. So you'd have like a patient on the table and you'd have like four arms of the robot kind of going into their mouth at the same time, and somebody on the little like robot console moving it around to try to treat these patients with surgery as opposed to radiation chemo. Um, Thinking that maybe, if we can avoid radiation in the head and neck, maybe we can help with swallowing outcomes. It didn't show any difference in overall survival or progression-free survival, so it showed that it was, a reasonable option, but really didn't show any statistical difference in swallowing outcomes at 5 years. Unfortunately, there were 3 deaths as part of the Orator and Orator 2 trials, and so it has been kind of, I feel like people are moving away from it. It's a very controversial topic, but a lot of people ask me, hey, can I have surgery for this? The answer is likely not. Most people undergo radiation and or chemotherapy at this stage in the province of Ontario. While we're talking about that, kind of wanted to touch a little bit about what people experience in terms of like post-treatment effects. And I find, for a lot of people, this diagnosis is not the thing that is going to kill them, but it's the thing that actually makes their life a lot worse or changes their life a lot. People get really bad dry mouth after radiation to the point where sometimes they get dental decay. Swallowing is a big thing, and this has been studied extensively. Pretty well every head and neck center will have like SLP, speech language pathology on staff to help with these patients and their swallowing outcomes. Many people, especially if we can kind of have a smaller radiation field, many people will be able to swallow after, but they may need some modified textures. There are some people who do need tube feeds after, and maybe even though, they didn't have any problems swallowing beforehand, may end up on a G tube lifelong afterwards. Speech changes. So we talked a little bit about that Kermit the Frog voice. That can sometimes persist afterwards. I I can often tell just by hearing if somebody's had an oropharyngeal cancer or radiation. And that's just because I hear a lot of people with this type of issue. And then unfortunately, the high doses of radiation do make it really difficult to talk about salvage therapy after radiation. So, surgery is really difficult afterwards. Second courses of radiation chemo are uncommon. I did want to touch on non-malignant HPV related lesions. So a lot of things that I see in my office, so this is an oral papilloma. This would be related to HPV 6 or 11. So those benign variants that we talked about, still covered by the Gardasil vaccine, which is great. I just put a couple of pictures here. They can be flat. They can be kind of like look like a little cauliflower. They can have those little finger-like projections that you see there. Usually you don't see like a firmness underneath it. So I always encourage people to like if they see a weird looking thing in the mouth, to actually not only just examine visually, but also examine like and also palpate. It's a huge part of your physical examination. So with something like this, you won't feel like a lump underneath. You'll feel just the exophytic piece. Usually they're not painful. Usually they don't bleed unless somebody bites them. And we treat these just with surgical excision. Sometimes we can use a laser. I put this up here to kind of differentiate a little bit between a papilloma at the top and what is essentially an oral cavity cancer at the bottom. At first glance, you might think, oh yeah, it's an exophytic lesion, like great. But the difference is often bleeding and pain in people who have a cancer. That thickness to palpation, so when you feel it, you're like, oh yeah, there's something further deep. You might see an ulcer. So if you see on the bottom, there's like that little kind of divot ulcer on that lesion. And then this will be growing. This will be growing and changing, as opposed to something that is like, over the course of years and decades. Like this will be growing over the course of weeks and months. I did want to speak a little bit about recurrent respiratory papillomatosis. So this is again HPV 6 and 11. This is near and dear to my heart in terms of my practice in laryngology. This can be either what's called juvenile onset, which is really more congenital, usually presents under 5 years old, or adult onset. Congenital is actually one of the causes of neonatal stridor. So if you ever see a baby with stridor, we think about RRP as a cause. And vaccination of mothers with HPV, with the HPV vaccine, has actually shown to show a decrease in congenital RRP. So that's a big deal because congenital RRP can be devastating. It's a lifelong disease. It's something that we can't cure, we can only treat. Um, it can be like very limited, like this, on the left-hand side of your screen, very significant, causing airway obstruction. Um, these um, these things don't go away; they are just treated, right? And treatment includes excision, laser excision, microderbrider, sometimes systemic treatment, or even things like intralesional bevacizumab. Um, and then we can actually see these lesions at pretty well any squamocolumnar junctions, most common in the larynx. But it can be, I have a couple of patients with nasopharyngeal RRP, you can have tracheal RRP, and even like if, for example, somebody is having such bad RRP that we put a tracheostomy in, that creates a squamocolumnar junction and you can get RRP coming out of their tracheostomy. There is a 2 to 3% risk of malignant transformation here, which again would be an HPV related disease. So briefly, kind of, I did want to touch on vaccination, because I know this is, something that comes up a lot, right? And so our HPV vaccine is Gardasil, originally was quadrivalent, now nonavalent. We talk about Gardasil in terms of cervical cancer a lot. And I think that's what it's known for in the community, is like, oh, Gardasil, cervical cancer, great. Um, it's the same virus that causes like HPV related oropharyngeal squamous cell carcinoma. So like there are certain head and neck cancers that will be prevented with like overall vaccination with Gardasil. Um, we used to say, oh yeah, only people with cervixes need this. Like, no, I think this is something that we should be considering. The recommendation is like, I think 26, for, if you talk to the powers that be, but realistically, like there's no reason that someone over 26 can't be vaccinated. The reason we recommend a younger age is that basically people at a younger age are unlikely to have come into contact with these HPV variants, right? And then it's considered over a certain age. Well, maybe you've already come into contact with HPV, like sucks to be you, right? But what if these people might go on to have future partners, right? We live in an age where you don't just get married at 19 years old and have the same partner for 60 years anymore. What if these people came into contact with one strain of HPV? Let's say they came into contact with HPV 33 or something, but really they haven't come into contact with HPV 16 yet, and that's the big one. That's the big head and neck cancer one, right? So um, there has always been this kind of stigma around HPV vaccination, in that it's like, oh well, if I just you know don't get this disease or something, I don't need the vaccine. Well, 90% of people come into contact with HPV at some point in their life, and you know that's a pretty high number. So I try in my practice to explain that HPV is not something that we should have a stigma around, right? It's not something that we should try to be ashamed of or try to ignore. Um, we now have evidence that head and neck cancer can be caused by this virus as well. And that, like, those papers came out in like 2010. They're not like things that we have known for years and years and years. But this is a reason that we should be trying to protect people of all genders. And the vaccine is approved up to 45 years old, right? I know, recommendations and approvals are different, but if your patient comes to you at 30 saying, hey, I've heard about this HPV vaccine, what do you think? That's an opportunity, right? People don't come into my office to ask about HPV vaccination. They just don't. They come to their primary care team. They talk about this as a prevention strategy. And so including a talk about head and neck cancer, which is more common in men, right? In this discussion, I think broadens our indications for vaccination and broadens our thought about who might be a good candidate or who might be, reasonable, especially if it's something that, for example, is covered by their insurance plan, right? I recognize it's not like covered for everyone anymore or everyone at this time, but this might be something that people are interested in having. And I think it's very reasonable and very, I think, appropriate to be talking to people who are, even up to 45 years old about this issue. So I'm kind of coming to the end of my talk. One thing I missed was I thought I was going to talk a little bit about how to do a full head and neck exam. So I'll touch on that very briefly now. Essentially, I always do the exact same head and neck exam for every patient that walks into my office. I start by looking in their ears because if I don't look in their ears, I will forget. And then I kind of do a quick like anterior rhinoscopy, just kind of look up the nose, looking inside the mouth. I use 2 tongue depressors. I kind of go all the way to the back of it's actually the patient's right side with the 2 tongue depressors, and I kind of walk the tongue depressors along the buccal mucosa. So I'm seeing the outside, the whole buccal mucosa and kind of the outside of the gums. I go all the way from the back on one side, all the way to the back on the other side. And then I do the same on the inside lining of the alveolar ridge, both top and bottom. I look at this at the hard soft palate. I look at the tongue and get them to stick their tongue all the way out over to one side because I want to get all the way back to the retromolar trigone, all the way out, all the way to the other side, tongue up, tongue down. It's a workout, but a full head and neck examination is like really important. And then I palpate. So if I can give you kind of one key point here is that inspection and palpation are important here. Don't be afraid that you're going to make your patients gag. You will. It's okay. I do exactly what I looked at. I palpate all of those surfaces. So outside of the alveolar ridge, inside of the alveolar ridge, floor of mouth, hard palate, both sides of the tongue, top of the tongue, bottom of the tongue. And I palpate into the oropharynx. So I kind of sweep my finger from one tonsil all the way to the other. It's it's part of your physical examination. And then I do the neck after that. So I do all kind of basins of the neck levels, like 1, 2, 3, 4, 5. Looking for all of those things. So I think it's just a really important skill. I think it's an important thing that you can add for your patients. If you have any concerns, you send them for nasopharyngoscopy, send them to me. You can see in, a cooperative and healthy patient, it takes me 30 seconds and I can see so many things. And then my last key point I want to talk about was that HPV vaccination prevents head and neck cancer too. It's something we don't talk about as part of our routine discussion, but it definitely it has been shown to help. It will be shown to help. HPV cancer of the head and neck is on the rise, and this is something that we can help do to stop it. So that is me. You got my email there in case there are any questions. I think we've got some time for questions now. I put my office number on there mostly because if you have a patient that you're worried about and, for example, says, oh yeah, like their appointment's not for 3 months or something, like you just call my office essentially. So anyways, thank you so much. I really appreciate the opportunity to talk with you today.
Perfect. Thank you so much. And we do have a couple questions for you.
Oh, great. Okay.
So there's one in the chat, just more in line with what we were just talking about. So I'll start that one first. So is there a role for vaccination in patients over 45 that are divorced or single and have new partners?
Love it. Absolutely. So the studies have been done up to 45, but there's no reason why you can't vaccinate above 45. One of my favorite OBGYNs that it's hanging around the internet, Jen Gunter, got herself vaccinated over the age of 45 because it just wasn't available to a lot of us, like when we were 16 or whatever, right? So this is something that's like certainly like harm reduction. You can talk to your patients about the fact that this, it's been approved up to 45. It's just because the studies haven't been done above it, that it hasn't been. It's not that there's a problem or something wrong with it. It is, and then it's really about mitigating future risk. I can't stop anything that's happened before, but yeah, if you are divorced, if you're having, additional partners, if like for whatever reason in your life, this is something that can help prevent future exposure to HPV. So I would say yes is my answer. I don't have like the, approval from the drug companies to back it, but absolutely I would talk to my patients above 45 if they are in that situation or if they even are interested.
Perfect. Thank you. Next question. What is the role of neck ultrasound for first step of trying to diagnose neck nodes?
Ooh, okay. This is I think this is a long topic. In my opinion, a neck node that is concerning is a neck node you can feel for most patients. So I get a lot of referrals that say like nodes on ultrasound, don't know what to do with it. So the current guidelines are we actually measure lymph nodes in the neck by short axis. So you'll get a lot of ultrasound reports that actually show you like the long axis, and it's like, oh my gosh, is this 2 centimeters in the long axis? But the short axis is 8 millimeters. So if it's under a centimeter, depending on where in the neck, sometimes a centimeter and a half, in the short axis, it's actually normal, believe it or not. And so I don't routinely send my patients for neck ultrasound unless I can feel something with my hands. Um, I think that routinely sending patients for neck ultrasound without a specific reason to, I think that increase, so it really generates a lot of like additional ultrasounds because you get something that's like, kind of borderline. Should we look at it? And then it also gives patients a lot of anxiety because they think they have cancer, right? Can't I tell people all the time, cancer is not subtle. Cancer does not go away. It's something that is there, and usually you can see it if you do a good head and neck physical examination. Things like lymphoma present with rapidly growing, big chunky lymph nodes. Things like head and neck cancer, you will see a firm, fixed, golf ball in their neck. And so my opinion, and everyone I'm sure has different opinions, but my opinion is that a good head and neck physical examination is infinitely more valuable than kind of ultrasound is in early stages.
Perfect. Any increase in other cancers post-radiation, thinking especially for younger patients?
Yeah, so um, unfortunately, yes, I suppose. So any radiation, like there's obviously like a risk of secondary cancers later down the road. I don't have the data on exactly what that is for specifically head and neck or oral cavity, but we do see recurrences. We do see secondary cancers. We do see sometimes rarely like lymphomas and stuff or come up after. They usually are decades later. So yeah, younger patients, you might see someone who had head and neck cancer radiation in their 40s or 50s, and then they're showing up in their 70s with a new cancer. Unfortunately, it's a risk benefit, right? So you have to kind of decide, this is the treatment that we have for this issue right now. If we don't treat it, this patient's going to die of their first cancer, right? So it is an unfortunate reality. I would say that it's a small group of people, but it does happen. But you have to kind of think about, you can't not treat the primary for fear of a possible secondary later down the road, I guess.
Perfect. We have had several patients recently with a partner with cancer due to HPV, and they are asking for testing for themselves. From what I
Okay.
understand, even if testing was available, it wouldn't necessarily be helpful, correct?
Yeah, so there's really no testing. I have a few of these patients in my practice because like the partner comes to the cancer meeting with me and then they go, "Oh my God, what about me?" Like which is fair, right? So I sometimes will offer these people like serial exams. If they're really anxious. So I have a few partners that come into my office just for their like, Q6 monthly or Q yearly like head and neck exam. And at some point I say, okay, so here's the deal, we've been doing this for a year or two. I do not see anything. Here are the symptoms you're looking for. But you're right, there is no screening for partners. I do sometimes tell people, remember that these HPV infections happened years ago, years and decades ago. So the chances, it's not like you're going to get cancer now from your partner who has cancer now. Likely if you had an HPV infection from your partner, it was years or decades ago, and you probably already cleared it. If not, we will deal with that when it comes, kind of thing. But I wish it would be so nice if I could just do a quick little screen. But I cannot.
Perfect. And then a few more questions that aren't, oh, actually, sorry, I see another one.
Oh gosh.
Are we seeing a fall in HPV head and neck cancers in areas with Gardasil vaccinations of both sexes?
The short answer is yes. The long answer is I don't have enough like long-term data to support it, but on more of like I don't want to say anecdotal, but more like I guess anecdotal is a bit better. Um, yes, but because the time frame is so long, I don't have the actual data to support that just yet.
Perfect. And then a few questions regarding referrals and
Yep.
patterns. How would one make a referral to you? Is it through Ocean or
I am on
different?
Ocean. I'm on Ocean as of like last week. So you can send it to me through Ocean. My office, I can send you my office fax. It's 905-721-3544. So same digits at the front, but it's 3544. You can send me a fax. I love faxes. But I am accepting referrals on Ocean too.
Perfect. And then in that referral form, what should be included to make it an effective referral for
Oh,
you?
I love that question so much. So primary symptom, onset, any risk factors, so like smoking status is huge, progression. So for example, dysphagia, not as great of a referral, but patient with progressive dysphagia to solids over the last 3 months, with otalgia, that to me, I'm gonna go, oh, I'm gonna see that person next week, right? So as opposed to if you just put swallowing, that is probably a 3 to 6 month referral because I don't know what that means. So as much detail as you have, like if there are concerning features, I will see your patient, I promise.
Perfect. And that was actually going to be my next question is what is the expected timeline to see a patient?
Yeah, so if there are red flags, I make extra time. I see these patients, like I see them at the end of the day, I see them over my lunch hour. For something like, for example, Globus, probably 6 months, 3 to 6 months. For something like if you're talking about like ear infections for kids, I try to see them in about 3 to 4 months. The more details I get in a referral, the better I can triage them. So if it's if it's like, hey, this patient has a sticky throat, it's probably going to be like, yeah, between 3 and 6 months. But if you are concerned about a cancer, you make it clear and I will see them.
Perfect. I do see a few more questions
Mhm.
regarding HPV specifically. So if you become immunocompromised and you have
Yeah.
previously cleared an HPV infection, can it return or flare up?
Yeah. So I guess the question is whether you can get a head and neck cancer because of becoming immunocompromised. And the answer, I don't have the data to support that answer, but I believe yes, because I have seen people who are immunocompromised present with their like with their first presentation after that. I think it's yeah, I think that would be an interesting study, but I just don't know that I have the answer for you. I'm sorry.
No, that's perfect. And I do recognize that it is 8:59. Shannon has posted in the chat. So we previously hosted a webinar with Dr. Nancy Durand around adult HPV vaccination.
Okay.
So for additional questions, I would encourage those to go watch that webinar, which is found on our website and our YouTube channel. And then for this webinar, it will also be posted to that same to our website and to YouTube as well. So thank you so much for your
Or if
presentation.
you have
It was
questions, you can email me. I'm bad with email, but you can email me. It's there. I will get back to you if you actually have questions. I'm more than happy to help.
perfect. Thank you so much for your time and for all this great information. It was wonderful.
Thank
And
you.
yeah, we really appreciate it. So thank you so much.
Awesome. Thank you so much, everyone.
Take care.